Hello, welcome to this episode of Case Bites. My name is Dr. Jay Mohan. I am the program director for the McLaren Macomb Oakland Michigan State Cardiovascular Disease Fellowship, and today we're going to be discussing cardiogenic shock. So, I recently had a patient that came to my institution. They were a middle-aged man, actually vacationing from India. He presented to our emergency room with 5 days of chest pain. Actually, what happened was he was having chest pain over and over again at home. A little bit reluctant to go to the emergency room due to insurance issues, the fact that he was vacationing here from India. And what happens is he actually has a cardiac arrest at home. So he arrests at home. Fortunately, it was in front of some bystanders who did do CPR, which saved his life. And he was brought to the emergency room and intubated in the emergency room for airway protection. When he got to the emergency room, the family was saying that he was having a lot of chest pain prior to the arrest, so they did an EKG, and this is the EKG that they found. Excuse this EKG for a lot of artifact, which is all this little kind of wiggly lines that you see, but what you see mostly here is the patient has sinus rhythm, but more importantly, in leads 1, 2, and 3 and AVF, the patient has ST elevation, as well as some reciprocal depressions in 1 and AVL, as well as V1 and V2. So my concern with this patient is that he has a large inferior wall MI, possibly involving the posterior wall. Sometimes you see that with involvement of V1 and V2. So when I'm going into the cath lab, I'm concerned that he has an occlusion of his artery called the right coronary artery. So this is what we found on coronary angiogram. I'm going to start with the second video actually first. And this is kind of the scary moment when you take a picture and you're like, oh my gosh, this guy has extremely severe coronary artery disease. This is an image. We actually had to go femoral or from the artery in the leg because the patient was showing signs of potential cardiogenic shock or low blood pressures. So we took a picture, and you can see here that this basically he's missing the main artery of his heart called the left anterior descending artery. It appears 100% occluded, or CTO, or chronic totally occluded at its mid portion. There's a large diagonal branch that almost functions as a secondary LAD or a twin LAD. And it has a ostial, or beginning of the artery, has a 99% blockage as well. And here's another image of the left coronary system. You can see that diagonal. There's actually 2 diagonal branches there. And then the circumflex looks severely diseased as well, with multiple 90% blockages. So immediately when I take a picture of this artery, I'm very concerned. He's got severe diffuse coronary disease of the left coronary artery. And when I shoot the right, I can see that the right coronary artery is the culprit, as we expected, based on that EKG. Looks like a large filling defect in that mid or proximal portion of the LAD, concerning for a blood clot. And when I tried to put the wire down, I got a little bit concerned as it wasn't going very smoothly, making me think there was probably severe blockage there. Additionally, whenever I do a heart catheterization, I put a catheter inside of the left ventricular chamber, and I measure pressures, and we look at something called the left ventricular end diastolic pressure, or LVEDP, which is 21. It wasn't extremely severely elevated, but we do use a cardiogenic initiative protocol that was actually developed in Detroit. And anytime the LVEDP is over 16, we get a little bit worried that the patient is grossly fluid overloaded. But the patient's blood pressure was stable, so I felt okay just intervening on this artery without consideration of something like what's called mechanical circulatory support, or a axial flow pump like Impella or balloon pump for support. So moving on to what we did next. The next thing I did was having a lot of trouble wiring the vessel here. So what we usually use is an 0.014 wire, which is usually the size of your hair. We try to wire it down usually with what's called a workhorse wire, or really soft tip wire that usually goes really nicely, smoothly through the artery, but this one was not going smoothly. So I decided to use a different wire, which is usually what we usually escalate to is a tapered tip wire or polymer jacketed wire that's hydrophilic, or basically likes to really get slippery and get through tight little channels. And I still could not wire that. So what I did was I took a gamble, and I took a balloon, and I did something called the Dotter method, where I kind of put the balloon in and out trying to create a channel. Still unsuccessful. So I gently ballooned that area, and which did allow me to get the blood, the wire down. And as I inject, I can see I'm actually still within the architecture of the blood vessel, making me understand I'm not in the dissection flap. So I feel okay continuing to push equipment through there. So obviously these are very concerning. I have a polymer jacketed wire down in the bottom part of the right coronary artery. So I'm getting a little bit concerned because that wire is pretty aggressive. So I have to be very careful to make sure that doesn't go anywhere else. So next, what we do is we decided to take a small balloon, and we also took a special catheter called an export catheter, which is a thrombectomy catheter, to kind of suck out that blood clot that was seen in the beginning part of the right coronary artery. And this is after we did aspiration thrombectomy on that. And you can see here significant improvement of the flow to the vessel. We could see there's a large, distal vessel, kind of small posterior descending artery, and a large posterior lateral ventricular branch. And the next thing we decided to do was stent that lesion we saw in the proximal RCA with a stent. And we can see here we have significantly improved blood flow to the right coronary artery. So at this point, we're feeling decently good. I'm sorry, that was the balloon. So here's what we use at intravascular ultrasound to kind of understand, is there more of the lesion that we need to treat? Is there further blood clot in there? So then we take a further balloon and really make sure we've dilated that lesion well enough to put a stent in. And then here we've deployed the stent, and you can see that the stent is in the mid portion of that right coronary artery, and we have significantly improved flow to that distal part of the artery. There's a lot of disease in that posterior descending artery, which you can see in this image right here, kind of in this area over here. But we kind of leave that alone. We think we have a good flow, and that's part of the art of being an interventional cardiologist. You don't always aim for perfect. You aim for what gets the patient stable and what gets the job done. And I think this was a very acceptable result. We look at TIMI flow, which is a fancy term for how brisk does the contrast get to the distal part of the vessel, and it's flowing very nicely. So I felt good leaving the rest of the disease here for medical treatment. So this is what we aspirated out of that artery, which is a couple blood clots. The patient had this condition called slow reflow, which is the concern when you have a lot of blood clot. You can actually push some of it into the distal vessel, and specifically in the microvasculature, the small little capillaries of the heart. So we give special medications. In this case, I gave intracoronary adenosine. Other options are like Nipride, verapamil. There's many different options. I like adenosine. I feel like it works well. It doesn't affect the blood pressure. And at this point, after that happened, the patient did have episodes of low blood pressure. So we did have to put the patient on Levophed. And notably, I got some lab work back, and the creatinine was noted to be 2.5. So right now, just to summarize, I've revascularized the patient. Their flow to the RCA is good, but they had a little bit of no reflow during the case. So I know the microvasculature is a little bit dysfunctional, and now they're on a little bit of pressors. So whenever you have a sick heart, you don't want to add more to the picture by putting patients on vasopressors, because it increases what's called systemic vascular resistance. And you basically have the heart that's a pump, and it's already sick, and it has to pump against more pressure. It creates even further issues and a spiral of cardiogenic shock. So at this point, I'm thinking the patient likely needs some degree of mechanical support. So what I did was I always further assess the patient with a right heart cath. So this is a Swan-Ganz catheter going into the pulmonary artery. And these are the numbers that we get. So there is significant pulmonary hypertension, but more importantly, the wedge pressure is now 30. So that's a surrogate marker for the left atrial pressure. It shows that the patient's significantly volume overloaded and in heart failure, basically. The other things I noticed is that the cardiac index, which is a marker of how well the heart's pumping, stroke volume times heart rate, is the cardiac output. And we divide that by the body surface area, we get cardiac index. When it's this low or below 2, we get really worried that the patient's having cardiogenic shock. We also calculate things like cardiac power output, PAPI, other numbers that are a little bit more complicated. But overall, this patient had episodes of cardiogenic shock. And more concerning is when I injected the artery in the leg, the artery is extremely small, limiting my options for mechanical circulatory support. So I decided to place what's called an intra-aortic balloon pump in this patient, which basically inflates during diastole to push blood into the coronaries and then deflates during systole to kind of create a suction effect to help unload the heart. And so a lot of the times, intra-aortic balloon pump is enough to support the patient. So we put the patient on that. Fortunately, they were able to come off of the vasopressors. The patient remained intubated. And we actually decided to transfer the patient over to our bigger hospital to be considered for other interventions, specifically of that left coronary system. Right heart cath numbers continued to demonstrate the patient had cardiogenic shock. So I did place the patient on dobutamine to help the heart kind of contract and help perfuse the patient. The patient did well. That you were able to extubate. There was no issues with the leg where the balloon pump was, but we were unable to get the patient off of dobutamine. So I needed to figure out a way to get this patient out of the hospital. So what do I do at this point? The patient's got significant coronary disease. Do I need bigger devices like left ventricular assist devices like LVAD or Impella? What should I do? So I spoke to the transfer team. We spoke with our surgeons, and we thought the best option was let's get as much blood flow to the heart as possible. So let's go with staging that left-sided, that diagonal branch we were worried about. So I did something called low contrast PCI, where basically I take a very limited amount of pictures. I base everything with intravascular ultrasound, and I was able to deploy a stent and improve significant flow to that diagonal branch, which was just enough blood flow to basically get this patient off of the balloon pump and off of the dobutamine. So the patient does well. They had a little bit of hemoglobin issues to be expected. We were able to get them off of the balloon pump, and actually they were discharged home about 2 weeks after this presentation on optimal medical therapy. I saw the patient in office. He did great, and he actually flew back to India basically 2 weeks after this heart attack. And he has contacted me by email, and he's still doing great. So really awesome presentation, really complex. This is what an intra-aortic balloon pump looks like. Basically, it's just a balloon inside of the aorta that inflates and deflates. The unique thing about it, it has a significantly lower profile than other devices that use 14 French holes. This one only used an 8 French hole, which is important because the patient had very small blood vessels in the leg. So it's really useful. I think it's fallen out of favor. Everyone goes to the device called the Impella nowadays, but I still have a lot of use with this balloon pump strategy, as you can see in this patient who did very well. So overall, the data in intra-aortic balloon pump is limited. I think there's a lot of interest now in cardiogenic shock. The DanGer MI trial was recently published at American College of Cardiology, supporting the use of Impella, specifically in cardiogenic shock. So we have a lot of support for using mechanical support devices in these patients. So hopefully we'll learn more. But there's, I think you need to be facile in all of the devices that we have. And I think this shows a good case of intra-aortic balloon pump and its use in cardiogenic shock. Just some more evidence to support that. And overall, I think you have to understand the treatment of shock, that you can't just do one thing. You have to be able to think outside the box. You have to be able to understand the medications that are used, like dobutamine, like Levophed, and when to use mechanical support, mainly by using the data that we collect with hemodynamics, the right heart cath numbers, and understanding when the patient needs to be escalated and de-escalated. So our take-home messages is, I think cardiogenic shock is a spectrum. There's limited data for all of the devices. There's a hub and spoke model that there's smaller hospitals and that we have to initiate transfer at times to bigger hospitals. And there's many different devices. We have to know the role of each device, and we have to know how to deal with the complications that can occur. But overall, I think this patient did excellent. We demonstrated how cardiogenic shock can present from a stable form to an unstable form. And I think that it's very important because as patients get older, as we start to tackle more complex disease, as technology continues to improve, we have so many devices at our whim. We can basically use anything, but you have to be a good interventionalist. You have to understand all of them. And I think this case really demonstrates that. So thank you for joining this series of Case Bites. I hope to see you in the next episode. If you have any questions, please reach out to me on Twitter at Dr. J. Bohan or on Instagram at Cardiology on Call. But thank you for joining us. Take care.